Good day and welcome to the second part of our lecture series on sexually transmitted infections. And during this second part, we will discuss what we call male urethritis syndrome. It means that the sexually transmitted infection that cause discharge in men or in male patients. Okay, so it can be gonococcal or non-gonococcal sexually transmitted infections in men. So that's what we call male urethritis. So I say that we will discuss gonococcal and non-gonococcal male urethritis syndrome. I am Teke Apalata. I am a specialist in clinical microbiology. So let's start this presentation with a clinical case or a clinical problem from a patient, and from there we will see the approach to a STI patient. We have a 24-year-old heterosexually active male who comes to you with complaints of a 2-day history of dysuria. It means that the patient experienced pain during urination. When he's passing urine, he feels pain or burning in sensation when he's passing urine. And he does not have fever. There is no fever, no urgency, no frequency, no hematuria. So there is none of these other signs. It's just painful urination that he complains with for the past 2 days. Okay. Remember what I said in the first part, that if you have a male patient at this age, a young male patient, like in this case, 24 years, heterosexually active, usually with dysuria, you can suspect a urinary tract infection, but urinary tract infection, it's really rare in men at this age. So you immediately need to think also of a sexually transmitted infection, although you will do a urine analysis to try to establish, if not, to prove or disapprove the hypothesis of a urinary tract infection, but you have to think of a sexually transmitted infection in this patient as well. Now, on physical exams reveals that there is no suprapubic or costovertebral tenderness. Why do we look for that? We look for that because we suspect that, okay, this patient has dysuria, it might be a urinary tract infection, so you look for suprapubic tenderness, or you look for costovertebral tenderness, just in a case it's an upper urinary tract infection that we call pyelonephritis. But again, it is not supported because this patient does not have fever. If this patient had fever, you might also expect maybe a case of pyelonephritis, but I already said that the urinary tract infection is very rare in this situation. But then, when dealing with a situation like this, you also need to check to do a genital exam, or a urologic exam reveals there is a presence of a mucopurulent urethral discharge. So there is a discharge coming, but the testes are non-tender, so non-tender testes, normal prostates. You really don't expect much in when it comes to prostate in a 24-year-old male, and no other penile lesions except for the discharge. So this is what you see, except for this discharge. So what it tells us from the history, it tells us that many patients who can come to you, even if they suspect themselves they are having sexually transmitted infection, they try to to hide the entire history. He will only tell you, the patient only tells you about difficulty or in passing urine or painful urination. That's all he is giving you. So if you don't examine, you don't do a physical examination, a genital examination, you will not see, this discharge. So some patient will not tell you exactly what they have. So that's one thing you need to be very careful of, So you have to see, you need to check, okay? Then of course, you need to do a urine analysis. Urine analysis, you find that it's positive for leukocyte esterase. What it means only is that there are the presence of white blood cells, like mainly neutrophils that are there because they are the one that produce leukocyte esterase. So it's a rapid test that you can do, in the doctor's office to try to find out if there are cells in the urine, in the past cells in the urine. But it's negative for nitrate and there is no blood in the urine. So what it means, a negative nitrite test, there is a test, one other rapid test that we do, a dipstick urine test that we also do. And we know that among the causes of urinary tract infection, community-acquired urinary tract infection, one of the commonest causes we have mainly Escherichia coli, that is E. coli, or you can have Proteus mirabilis, or you can have Klebsiella pneumoniae. So those causes of community-acquired urinary tract infection, those pathogens belong to the big family of Enterobacteriaceae. And those bacteria, they are able to convert nitrite from nitrate, okay? So that test, if you do it, it will become positive. So if it's negative, although you cannot 100% exclude the possibility of urinary tract infection, but at least if you look at the fact that he is a male patient, 24 years, where UTI is very rare, and the nitrite test is negative, of course, and you see that there is a discharge coming in, it's highly likely that this patient does not have urinary tract infection, but the patient has a sexually transmitted infections. Okay, so then you have to collect a swab from here, So what you do is with a gauze, you can remove this excess. Then you can have a PropTech swab that you will insert in the urethra, just very careful. You insert it shortly and, you rotate it, 360 degrees to collect an appropriate specimen that you will put in a transport medium that you can send to the lab. Okay. So then you send to the lab where they will do a quick gram scan and they will inoculate it in mainly in, if they want to do culture for Neisseria gonorrhoeae in NYC media, or maybe they can send it for PCR where they will look for the commonest pathogens of urethritis in the male patient, mainly Neisseria gonorrhoeae and Chlamydia trachomatis. So what is the likely diagnosis in this patient? It's, of course, it's high likely to be a sexually transmitted infection, but it's what we call male urethritis syndrome. So you are not sure yet what the cause is, but the potential etiological agent here can be Neisseria gonorrhoeae, it can be Chlamydia trachomatis, it can be Mycoplasma genitalium, it can also sometimes tend to be Trichomonas vaginalis, although it's very rare in men. So, but then you get the result. The patient, because the gram scan can be done immediately, and you get some information from the side lab. They reveal that there are about 20 white blood cells per high microscopic field. You already knew from the rapid test that you did, leukocyte esterase, that there are a lot of white blood cells, but here you can see that there are already plenty of blood cells, in the specimen. But they give you a very important information. They say there are no intracellular gram-negative diplococca seen. So this information is critical. So an intracellular gram-negative diplococca, it's actually what we call Neisseria gonorrhoeae. So Neisseria gonorrhoeae, it's found intracellularly, it's a gram-negative, and it's diplococca. So you have two coccas coming together 2 by 2, okay, that is seen. So it means that here they actually ruling out the possibility of gonorrhea infection. So if they are then ruling out the possibility of gonorrhea infection, what is the most likely diagnosis in this patient? Is it gonorrhea? No. We say that there are no intracellular gram-negative diplococca seen, so it's not gonorrhea. Is it acute prostatitis? No. This patient on a clinical examination, the prostate was normal, non-tender. Epididymitis? No. We found in clinical examination, physical examination, that the testes were normal, non-tender. Is it a non-gonococcal urethritis? Yes. So we say that the commonest causes here could have been either Neisseria gonorrhoeae or Chlamydia trachomatis or other causes that are non-gonococcal. So it's high likely that it's a non-gonococcal urethritis. It's bacterial cystitis. It's not a cystitis because we say that from the urine analysis test, it was unlikely to be a urinary tract infection. That is a cystitis. So in this case, the most likely diagnosis for this patient is a non-gonococcal urethritis. It's a non-gonococcal urethritis. So what is the most likely organism that is causing this condition in this patient? Is it a Chlamydia trachomatis? Yes, Chlamydia trachomatis is the cause, one of the non-gonococcal urethritis cause. Ureaplasma urealyticum, yes, it can cause, yes. Trichomonas vaginalis can also cause. Neisseria gonorrhoeae, no, it causes what we call gonococcal urethritis. Herpes simplex virus, it's very rare. So we can see that what is more common here as a cause, a likely cause of non-gonococcal urethritis, it's mainly Chlamydia trachomatis, but we cannot 100% exclude the possibility of ureaplasma or trichomoniasis, although they are extremely rare in male. So the answer, if you have to select one single best answer, it should be Chlamydia trachomatis in this patient. You have to suspect the possibility of infection due to Chlamydia trachomatis. Okay, so this is the approach to an adult male urethritis case. So you must know that we break down the causes in gonococcal male urethritis that is caused by Neisseria gonorrhoeae and the non-gonococcal causes. And non-gonococcal causes, the leading cause of non-gonococcal urethritis is Chlamydia trachomatis. So Chlamydia trachomatis, but then you can also think of other causes like Trichomonas vaginalis, Mycoplasma genitalium, Ureaplasma urealyticum can also be the causes of non-gonococcal urethritis. Okay, so the leading cause, we say, if you receive a patient with a urethral discharge, you think of Neisseria gonorrhoeae or Chlamydia trachomatis. Those are the commonest causes. That's why when we do a syndromic management to treat this patient syndromically without doing the lab test, we try mainly to cover Neisseria gonorrhoeae. We choose an antibiotic that will that can be used against Neisseria gonorrhoeae and Chlamydia trachomatis. That's why you see that we can give this patient one dose single start dose of ceftriaxone injections, that is a third generation cephalosporin, ceftriaxone intramuscularly, and we put this patient on doxycycline that belong to the tetracycline group, doxycycline 100 milligram BD for maybe 5 to 7 days, maximum 7 days with one injection of ceftriaxone, or we can put this patient on cefixime tablet instead of ceftriaxone injections. So because we are trying to cover the commonest causes, but it might happen that this patient comes back after 1 week. Next week he can come back, then there are no improvement. So probably, you missed some of the pathogens, although it's very rare, maybe you missed, okay? So, but we will look at that scenario later. So in summary, what we are saying that you have a patient who complains of urethral discharge. And sometimes I say you will not see a discharge. It might just be a dysuria, painful urination. In a male adult patient, it's enough to suspect a sexually transmitted infection. So you need to take an appropriate history, including the sexual orientation, and you need to do a full physical exam, if to try to see if there are no visible discharge, and ask the patient, if he does not see anything even by milking the urethra, if there is no discharge coming. You also need to provide counseling in this patient, test for HIV. Okay, then you will then empirically treat this patient by giving this patient ceftriaxone IM intramuscularly 250 milligram a single dose, plus either doxycycline, I spoke about it, or you can give azithromycin, that is a macrolide, 1 gram as a single dose. So, to try to increase the compliance, because sometimes with doxycycline for 1 week, the patient might not be compliant enough, and especially with the side effect of doxycycline, it's better you use ceftriaxone 1 dose, azithromycin 1 oral 1 gram single dose. It's very enough. Then you can give the patient an appointment to come back after a week to, after 7 days, that is 1 week, to try to reevaluate the situation. So, but then let's say that in examination of this patient, there was a scrotal swelling or painful testes and all that, you just need to be very careful. You need to examine this patient very carefully, especially if the testes are swollen. You need to make sure that you don't miss a condition called orchitis or hydrocele or hernia, and so on. So if you are not certain, it's better you refer this patient to the hospital where it can be seen by a specialist. Okay, so you can add ibuprofen, 400 milligram 8-hourly, just to try to reduce the pain if there is enough pain. But otherwise, you can still start this patient on ceftriaxone and azithromycin and refer the patient. So let's talk a little bit about gonorrhea, because we spoke about gonorrhea and chlamydia as being the commonest causes. So gonorrhea is caused by what we call Neisseria gonorrhea. And the Neisseria gonorrhea, remember, in that case, the most important clue that we got, that it is a intracellular gram-negative diplococcal. So you can see here, this is a microscopy slide. And all that you see are neutrophils or past cells, after doing a microscopic examination, what we call gram staining. And you will see this pink, tiny thing, cocci, cocci. And they are here. Here you can see they are 2 by 2. 2 by 2, that's what we call diplo. It means that they are 2 together, diplococci, diplococci. And they are gram-negative diplococci, okay, because they are pink in color, so it makes them being gram-negative And then because they are 2 by 2, you can see everywhere they are 2 by 2, and they are intracellular. You can find them here inside the cells, inside the past cells. So that we call intracellular gram-negative diplococca. So all you need to see is this to confirm the diagnosis of gonorrhea. Okay, so it is characterized by a purulent genital discharge, okay, and causing urethritis in males. But in females patients, we will see that in the next lecture, it causes what we call cervicitis. It causes cervicitis. It does not cause vaginitis. It causes cervicitis in women. In males, in men, it causes urethritis. Okay. And in women, sometimes it can be asymptomatic. So don't always trust women when they are asymptomatic. You still need to use protections, like use preservative or condoms, to try to protect yourself, because it might be subclinical, it might be asymptomatic. It can also cause anorectal and pharyngeal infections. So if you do anorectal sex, anal sex, or oral sex, or oropharyngeal sex, then these patients, depending on their sexual orientation, they are prone to develop gonorrhea. So if you are managing a patient with pharyngitis that is not responding to penicillin, you can also suspect gonorrhea infection, and treat accordingly. It leaded in men in important complications that we call epididymitis. Epididymitis in males, where they will develop really swollen, painful testes and all that. And sometimes it also leads to serious complications like infertility and all that. And in females, it causes salpingitis, the ovarian tubes that becomes inflamed. We will discuss that when we will deal with infection in women, or ectopic pregnancy, infertility, and in 1% of cases, it leads to what we call disseminated gonococcal infection. That's why you can have patient with gonococcal arthritis and so on. So it's a disseminated gonococcal infections. What are the virulent factors that this microorganism has? It has a lipopolysaccharide that is a branched oligosaccharide that allows for strain variations. That's why it's sometimes very difficult for scientists to develop a vaccine against some of the pathogens because of strain variations. And it has a structure that we call pili in its cell wall that is also responsible for both antigenic and phase variations. Okay, and also it has a predominant protein in its outer membrane that we call protein IA and IB. So they are also playing a major role as a virulent factors. And the organism adheres as well as penetrate and transit epithelial layers, but they don't really cause infection in epithelial layers, but mainly in mucosal structures. So it then it has, with all these its composition, it leads to a very weak antibody response, due to various antigenic variations. So it's not like you contract the infection today, when you contract next time, you might have antibodies to protect you. No, it does not happen. That's why we really don't have vaccine against it. So because of that weak antibody response that it leads due to antigenic variations. And it resists to complement mediated bacteriolysis. So it resists the action of our complement system that try to resist against microorganisms. It produces IgA protease that assist the microorganism to establish itself, and also antibody blocking mechanism. So there is no way your body can resist its effects. Okay, but one of the major problems when it comes to the treatment of Neisseria gonorrhea infection now, it's development of resistance, because we lost the fluoroquinolones. That was a very good antibiotic to treat Neisseria gonorrhea. In many cases, many reports across the world, fluoroquinolones like ciprofloxacin is no more effective against Neisseria gonorrhea. Penicillin, we lost it very, very many years ago. We lost now ciprofloxacin. We lost the third generation cephalosporin in many parts of the world, like your ceftriaxone. So we lost spectinomycin. That was a very good also antibiotic against Neisseria gonorrhea. So we have now a strain that we call multi-drug resistant Neisseria gonorrhea and extensively drug resistant Neisseria gonorrhea. So multi-drug resistant Neisseria gonorrhea is when you have resistance to one or more class 1 antibiotics, plus resistant to 2 or more class 2 antibiotics. So we have antibiotics that have been used against Neisseria gonorrhea classified into class 1 and class 2. You know, class 1 are the currently recommended antibiotic, like your injectable extended spectrum, your cephalosporin, or your oral cephalosporin, or your spectinomycin. And the class 2 are like the penicillin, the fluoroquinolone, the azithromycin, aminoglycosides, and the carbapenems, okay? So multi-drug resistant Neisseria gonorrhea, if you have resistance to one or more in class 1, and the 2 or more in class 2, that's what we call multi-drug resistant Neisseria gonorrhea. Or extensively drug resistant Neisseria gonorrhea is when you have resistance to 2 or more in class 1 and 3 or more in class 2. That's extensively drug resistant Neisseria gonorrhea. And here we really need to do the antimicrobial susceptibility testing to know what antibiotic we can use against this infection. Now, let's look at chlamydia infection, okay? Chlamydia is caused by, this infection is caused by what we call Chlamydia trachomatis. Chlamydia trachomatis is also an obligate intracellular bacterium. So it also only survives within the cells. We have almost 15 serotypes of Chlamydia trachomatis. But the interesting thing about this pathogen is that different serotypes, they cause different conditions. Like the serotype A, B, B, A, and C, they cause an eye infection, what we call trachoma. You know, there are patients who develop eye infection called trachoma. It's due to serotype A, B, C. But when you have serotype D to K, from D to K, they are the one that cause genital discharge, okay? But there are 3 other serotypes, serotype L1, L2, and L3. Those cause ulcers, genital ulcers, mainly a condition that we call lymphogranuloma venereum, or LGV. It's an ulcer, you know, it's an ulcer with inguinal BIBO that is there, playing inguinal BIBO, plus an ulceratic lesion on the genital area. They are caused by strain L1, L2, L3. Strain D to K, they cause discharge only. Strain ABC, they cause eye infection that we call trachoma. So that's okay, this infection, how it happened. Now, the life cycle of Chlamydia trachomatis, it's also very interesting because there are it presents in 2 forms. We have what we call elementary body and the reticular body, you know, elementary body and the reticular body. So everything starts here. Chlamydia elementary body, it's the one that begins the cycle. So the elementary body, it's the form of Chlamydia trachomatis. It's form that can survive outside the cell. Remember, we say it's an obligate intracellular. So it's an infectious form, but that is found outside the cell. It's extracellularly, it's infective, but it's not able to replicate. Since it can survive outside the cell, it cannot replicate, but it can infect the cell. So you can see here an elementary body that infects these our host cells. This is the nucleus of the cell. The elementary body is able to infect the cell. So if you are in contact with your partner who has chlamydia infection, it's elementary body that will infect your cell. Then it has the ability to penetrate your cell. Then from here, it will then, following a cascade of events like the chlamydia particles is then engulfed in DNA and RNA protein synthesis will start, and the elementary body will then convert to give reticulate body. So it was elementary body, it becomes reticulate body. Now, reticulate body is then the form of chlamydia that is inside the cells. It has the ability to replicate, but it is non-infectious. Okay, so it replicates here, you know, it replicates by the mechanism of binary fission. It then replicates. Then after it has achieved a high number, the cell will rupture. When the cell rupture, now it converts from a reticular body to elementary body. Then the elementary body will then be released outside the cells in order to infect many other cells. Then the cycle continues. That's where you develop a serious chlamydia infections. Okay, so it also has a different virulent mechanism, like the MOMS, that is a dominant target for antibodies that avoid but unfortunately does not lead to cross protections. And it also has the PMPs, that is surface that leads to a phase variant protein. And all this makes difficult for the development of a vaccine against Chlamydia trachomatis infection. It usually leads to a silent and asymptomatic infections, and that is leading to a major public health problem because you might not notice it until you have serious complications. And because of various serotypes, it can cause both sexual and non-sexual transmission. A non-sexual condition is like a trachoma, you know, and it is one of the major causes of non-gonococcal urethritis. So if you have a male patient who comes with a urethritis, if it's not gonococcal infection, it can be non-gonococcal, and that non-gonococcal is usually chlamydia infection. Okay, in women, it causes cervicitis that leads to ascending infection. Remember that from the vagina, it moves to endocervix, you know, to the ovarian tubes. That is ascending infection that causes salpingitis, you know, and it leads to the blockage of the ovarian tubes. That's why it's one of the leading causes of infertility in women. Or if a woman is able to become pregnant, usually it leads to what we call ectopic pregnancy. So it prevents actually the fecunded egg, you know, that is formed to go through the ovarian tube to come to the uterus cavity so that the child can develop into the uterus. And because of the blockage of the chlamydial infection, that fecunded egg will then, if the fetal egg will then remain outside the uterus, and usually you have a pregnancy in the abdomen instead of it being into the uterus. So that we call ectopic pregnancy. That is a very serious condition. And some of the children born from mothers who are infected with chlamydial infection will develop what we call conjunctivitis, so the infection in their eyes, or they can develop lower respiratory tract infections. So it is estimated that almost 500 million people are at risk of this infection, of which 140 million are currently infected with 6 million blind, you know, because of the trachoma it's one of the cause of many people becoming blind, because of chlamydial infections. So the treatment is usually the tetracycline group, mainly doxycycline. We use a doxycycline, or we use a macrolide like erythromycin, but mainly azithromycin. It's more preferred, especially in pregnant women where we don't use doxycycline. And beta-lactams are not effective against Chlamydia trachomatis. Now, why beta-lactam cannot be used? It's mainly depending on the structure of this bacteria, the structural wall of chlamydia infection. So this is the structure of gram-positive and gram-negative bacteria. But chlamydia is none of these. Neisseria gonorrhea is a gram-negative. Okay, but the structure of chlamydia is completely different from the structure of those two traditional gram-positive or gram-negative. In a gram-positive, you can see here a very thick peptidoglycan layer. Then you have a cell membrane inside, okay? And it has penicillin binding protein, PBP receptors, where the beta-lactam come and attach to the PBP in order to destroy the bacterial cells. And even in a gram-negative, you first have an outer membrane, that makes it different from gram-positive. Gram-negative has an outer membrane. Then you have a very thin peptidoglycan layer. Then you have the cell membrane inside. So that's why sometimes there are also some molecules that are not able to penetrate in a gram-negative because of the outer membrane. The porins of the outer membrane may block some of the molecules to come in. But chlamydia is none of this, because chlamydia has a completely different structure. You can look at its outer membrane. It's different from the outer membrane of gram-negative. Then you have a periplasmic space, empty space here with very different types of peptidoglycan that are there. And then you have the inner membrane that is there. So there are no receptors for beta-lactam drugs where that can work effectively in the structure of these bacteria. So that's why we only use either doxycycline, or we use macrolide like your azithro, that can work. So because of the structure of this bacteria, so you cannot select a beta-lactam against a chlamydial infection. Now, you prescribe, now let's come back to our patient, our 24-year-old male patient with dysuria. Now you prescribe an appropriate antibiotic regimen for this patient. And now this patient returns to your office 1 week later, stating that he completed his treatment. He was compliant with his treatment, but symptoms have not completely resolved, and he wants to know what is going on. Okay, so now you put this patient in treatment. 1 week later, the patient comes without satisfaction. So you need to explore a number of options, okay? The first thing is you need to establish that the patient was compliant with the treatment. He took the right doses, the right frequency, the way you explain. He did not miss his dose. So you need to establish that he was compliant with the treatment, because the first thing you have to look to try to find out if the patient was not compliant, okay? Then the other thing to consider is that maybe when we establish that this patient has a chlamydia infection, we rely on the results from microscopy, and due to the sensitivity of microscopy, maybe Neisseria gonorrhoeae was not found under the microscope, but we can then consider to do a PCR test to find out if we did not miss, Neisseria gonorrhoeae infection. Or maybe we did not miss an infection from a different pathogens, okay? So, or if in your empiric treatment, you did include a third generation or fourth generation cephalosporin to cover for gonorrhea, but this patient did not respond, then you also need to think of resistance. It might be also an issue of a resistance. Or then you might think of other pathogens like a Trichomonas vaginalis. That might also be the cause here. Maybe it's not Neisseria, it's not Chlamydia, maybe it's caused by Neisseria, by Trichomonas vaginalis. Or it was also a mixed infection that you treated others conditioned by Trichomonas, so you need to add metronidazole in this patient to try to cover for Trichomonas vaginalis infection. So it's something you need to think of. It can also be a question of reinfection, because what you need to do when you're managing patients with STIs, you need to identify their sexual partners. And if the patient tells you that he has 2 or 3 sexual partners, you need to give that patient 2 or 3 partner notification cards to invite all partners, because the partners need also to be treated. If you only treat the index patient, then the patient takes the medication, go back, still have unprotected sex with his different partners, so he will have a reinfection and come back. So you also need to ensure that it's not a case of reinfections. So this was a case of a patient to try to illustrate our approach to the treatment of a male urethritis syndrome. Now, follow us in the next lecture where we will now try to discuss a female patient with a vaginal discharge, whether it's a case of vaginitis or cervicitis, and how we will approach that female patient. It's coming in our third lecture on our lecture series on sexually transmitted infection. Thank you. Bye.